What you guys are looking at here is an example of the regimental surgeon's living quarters. So regimental surgeons, the medical officer for the regiment. Now, a typical 18th century Army regiment for the American Army is going to be about 480 enlisted men at full strength. Now, not every regiment's at full strength, but when they are at full strength, 480 men for one man is kind of a lot of people to take care of. He may, at best, have a regimental surgeon's mate assisting him. That would be his own apprentice. And likely the apprentice doesn't have the same skills as the master, obviously. And so in this case, he's pretty much on his own for taking care of all these guys. Now, that's not really his goal isn't really to take care of them all in every circumstance. He is here to help manage camp sanitation or camp hygiene. He is here to manage, camp health. And if something is seriously wrong with a soldier, he's not necessarily solving all of your problems. He's probably going to send you a lot of the major illness and wounds off to surgeons, or off to doctors in hospitals. So the Army has a system of Army hospitals, field hospitals, and flying hospitals they would set up specifically for the purpose of dealing with more serious injuries and illnesses, things that need a lot more care over a longer period of time. So when we think about the regimental surgeon, think of him more as dealing with your camp issues and dealing with you while you're in camp, as long as you can stay in camp, as long as you are healthy enough to stay in camp. But he's got the skills. He can deal with any of those problems if he doesn't have the ability to send you off to somewhere else or deal with you otherwise. So he can kind of take care of whatever illnesses and diseases pop up or injuries. Now, when we think of a military surgeon in the 18th century, what are some of the things that usually kind of pop up in our heads, things that we kind of think about? What do you think that he's dealing with?
Amputation thing, I think, creeps me out.
Amputation creeps you out the most. Guess what? It did for them too. In the 18th century, amputation is a fairly uncommon procedure. It's not something they're doing very often, and there's good reason for it. There's not usually a lot of need for it. Amputation is typically done in the case of infection. So in the case of a serious infection, or in the case of serious damage to a limb that is is irreparable by other means. So for instance, if like an artillery piece comes through and rips off half your arm, they may cut further up the arm to make sure there's a cleaner area for them to close the wound. That's a little tricky because that requires you to survive long enough for them to get to you in that case, which isn't always an option. But if it is, they may amputate in those cases. But those are fairly rare occurrences relative to the overall injury suffered by the Army over the course of the war. So, if, for instance, we are to go kind of in the route of what would happen to you to get you to a point where you're going to need amputation, the first thing you have to consider is, let's go with the infection route. You've probably gotten shot by a musket ball. Now, if you get shot by a musket ball in the 18th century, what you've probably been hit by is a lead ball about 1.5 ounces in weight, traveling at roughly 600 miles an hour when it leaves the musket. This bullet is going to be about 70 caliber out of the British muskets, about 65 caliber out of the French. But if you get hit by one, they're very heavy, very large. They travel pretty slow, but don't let that fool you. It's going to do a lot of damage. And if it hits you, it's probably lodging itself in one of two types of tissues, soft tissue or hard tissue. Now, what are some soft tissues you have in your body?
Organs.
Yeah, organs, right? Skin, muscle, fat, things like that. And if it lodges in soft tissue, typically surgeons are going to remove it first they're going to have to identify where the bullet is. That's the big concern initially, because the bullet's gone into you. It's probably not come out. They need to find the bullet first. You can use probes. It might look like this, metal point, or it might be a finger like this one. In these cases, your surgeons are going to want to use them differently depending on what's happened to you. So for instance, what might be the benefit of using my finger? I can feel the bullet, right? I can identify where it is much more efficiently without pushing and prodding and poking deeper in, causing more damage. This one might have a little more trouble with that, the steel one. So there's not always a perfect benefit to using the finger over, or the tool over the finger. And of course, regardless of either one, am I going to have either of these be sterile? No, but am I going to have them clean? Absolutely. Absolutely, they'll be clean.
No.
They will be clean, but they will not be sterile. You guys know what the difference is? There's a difference. There's a difference between sterile and clean. If we think about sterile and clean, think about the example I usually use. Imagine I get a cutting board and I put a big piece of raw chicken on it and I cut it up and I stick it in a stew. And now I've got all the little bits of chicken pieces and slime and all over this chicken cutting board. And I take a paper towel, I wet it, and I wipe the whole thing off. Have I sanitized the board? No. Have I cleaned the board though? Yes, there's nothing on it. There's no obvious sign that I've ever used it, that there's anything there, but I haven't sanitized it. Because of course, when I say sanitize, what am I getting rid of with sanitation? Bacteria, right? We're just getting rid of all the bacteria and stuff that could be on there as well. When I'm cleaning it, I don't see bacteria. I'm cleaning what I can see. I'm cleaning everything off of it. And so that's the big difference. So surgeons of the 18th century, they'll be very clean. They'll make sure there's no blood, no viscera, no anything on the tool they're working with you. They'll make sure there's no rust, nothing on the tool they're working on you with. But they're not sanitizing the tool. So whatever was on the tool when it went in one guy, those bacteria and whatnot will still be on the tool when it goes into the next guy. And of course, any tool, any bacteria that gets just laying around. And so the reality is, without sanitation, and of course, thing to remember in the 18th century, there's no germ theory. Germ theory won't exist for another 100 years. They've seen bacteria under microscopes and such, but it's going to take a long time before the medical system has had enough time to observe and understand and kind of identify what bacteria are and how they work in order to understand that they contribute to disease. That connection just isn't there in the 18th century, and so there are limits to what they can understand as far as that goes. So when a surgeon looks at you in the 18th century and sees your wound, he's doing what he can with the tools he has to deal with the wound. Infections are going to come later, and it's not something he's going to understand as being caused directly by him sticking things inside of you. And odds are it wasn't just caused by that. It's the bullet going in you. It's the fact that it's exposed to air and dirt and whatever else has gone in, piece of your clothing, whatever else is in that wound. Now, once we're removing the bullet from the wound, if it's in soft tissue, it might be easily moved enough that we can use a pair of forceps with these little divots on the end to very easily go in, grab the bullet, and remove. That might be easy enough using a pair of forceps, simple, basic. But in some cases, you might very well see times where bullets have gone into hard tissue. Now, what are some hard tissues in your body? Bone. Bone's the primary one that we mostly think of. And of course, bone's pretty hard. It's actually harder than lead in many cases. Lead, when hitting the bone, is not likely to break through the bone. It's oftentimes going to embed itself into the side of the bone. And as it embeds itself into the side of the bone, it loses its shape and it kind of embeds into the side. So a steel drill like this would be useful for removing that bullet from the bone, because that steel bit on the end of the drill is stronger than the lead. Steel is stronger than lead, so I can drill down into the lead of the bullet to get a good grip on it and then use the leverage to pull it free from the body. Now, once I've removed the bullet from the body, I have to close the wound. Any idea the best way to close the wound? Sew it up. That would actually be one of the very common ways to do so in the 18th century. But we have a concern. There's a concern there's going to be an infection. With a bullet wound in particular, they tend to associate bullet wounds with likely having an infection. If there's an infection and we sew it up, what might we have to do it? We might have to open it up later. Let's just leave the wound open. Yeah, leave the wound open. Give it a nice bandage. Give it a light bandage covering it. Right. Make sure it has air. Make sure it has the accessibility to air so it can heal. Make sure we can identify if there's any problems to it. So what we're going to do is we're going to make sure that wound's open, because the idea here is in the 18th century, they understand that they don't have a way to deal with infections effectively. They just don't. And they know it. And so in many cases, what they're doing is they're relying on the body itself healing itself, with them supporting the body in what it's doing. So if we work on this concept by itself, we think that, okay, they're leaving the wound open. That gives them the best opportunity to do two things. One, let the body heal on its own. Don't muck with it. But on top of that, the surgeon can also identify if there's anything going horribly wrong, because he can see the discoloration, he can see pus draining, he gets a good view into the wound. And so surgeons have a better way of treating this, being effective at treating this. If there is an infection in that wound, one of the things that's commonly done to deal with the infection, and in particular to deal with the smell of the infection, is they would use vinegar. Because in the 18th century, they generally associated smell with the spreading of disease. And so they would use something like vinegar, pouring into that wound to help get rid of that smell. And in the process, the acidity of the vinegar was actually very effective at killing off the disease, or the infection. Now, that's not to say that it's going to cure you. It's not going to cause all that is the infection to go away. But it's going to give your body a better fighting chance. And your body itself should help fight off that infection on its own. But the reality is that it isn't always successful. And eventually there may be starting to set in necrosis, gangrene, rotting of the flesh. And as this happens, you may have to remove the lower limb in the purpose of trying to prevent the infection from getting into the bloodstream and being pumped into the rest of your system. So in that case, surgeons may have to go to performing an amputation. Now, amputations are kind of gross, but they're not as grotesque as we tend to make them out to be in the modern day. They're very surgical, they're very clean, and very intended to be very decisive. So when you think of a surgeon performing an amputation, what's the first tool he goes to? What's the first thing he's going to use when it's time to amputate? A saw. Here's the thing. If I cut you with a saw, right? So I have a big old saw in here, big old bone saw. It's got serrated edges on the bottom. If I cut you with the serrated edge on the skin, what's going to happen to the skin? Tear. It's going to tear. Is that going to be easy to patch closed? No, I'm not actually going to be close that. You're pretty much going to die. If I do that, there's very little chance that I'm going to effectively be able to close that wound. And it's going to be, first off, very, very slow, very difficult, and you're probably going to die in the process. We don't want that to happen. So surgeons aren't going to start with the saw. What's the first tool a surgeon should start with when operating on someone performing an amputation? You're really close. There's one right before the scalpel, though. A tourniquet, yes, absolutely. Tourniquet first. So we would apply a tourniquet first. So secure that onto the arm or the leg, wherever we're operating on, with the intent of cutting off the blood supply as best as possible to keep blood from flowing into the extremity or out of the stump in order to keep you from bleeding out. So we want to reduce the chance of you bleeding to death. That'll give us several more minutes to work on you than if we had done it without that. Next thing, though, scalpel. Because we still have to get through the skin. And the other thing about the skin is that we want to leave enough skin around to close that wound cleanly. And so we're not just going to start to cut straight on. What we're going to do first is we're going to make an incision 3 cuts. And the idea is we're going to take a kind of a panel of skin, and we're going to kind of pull that back and hold that up here. So there's going to be a guy at the bottom, there's going to be a guy at the top. And there's going to be a guy holding your body as well. And there's a surgeon who's working in between the two guys. The guy at the bottom is holding the lower part of your arm. The guy on the top is probably holding the upper part. He's the one holding that piece of skin flat back, so he's not in anyone's way. That's the thing we're going to use to close the wound up closed later. So that's what we're going to use to close the whole wound and close it shut. No painkiller in the 18th century as far as for surgeries like this. So either you're going to black out because of the pain, or you're going to be conscious for the whole thing. Oftentimes, if you're conscious for the whole thing, I mean, what you're probably doing is you're definitely biting on a bite stick. So you're focused on a bite stick of something like this. If after the surgery you're having problems, laudanum would be used post-operatively to help deal with your pain. Laudanum is a distilled opiate mixed in alcohol, and that would be used to deal with your pain after a surgery, but any large doses during an operation are likely to kill you. So they wouldn't give you large doses during an operation, they give you small doses post-operatively. So yeah, during the operation, no painkiller for you.
Wait, why don't they just knock them out?
How would I do that?
By hitting them on the head hard?
In which case, I might have to go to this tool, because what happens if I hit you really hard in the head? Like, have you ever seen an athlete get hit really hard in the head? What happens to them? What do they get? Concussion, right? So your brain is rattling against the inside of your head. That's actually what knocks you out. But as your brain rattles and smacks the inside of your walls of your head, the brain's damaged. Now, the damage could be, fairly light and not actually be long-term harmful, although accumulated over time, it definitely will be harmful. But you will see times where, if that's serious enough, you might have blood vessels burst inside of your skull. And if that occurs, because you've hit them on the head like that, and it's actually something you really have to be worried when you hit someone on the head like that, and why they do concussion protocols and such, you could have subdermal hematoma, which is bleeding inside of the skull, inside the cranial cavity, that's going to start to pressure on the brain and crush the brain. Surgeons in the 18th century can actually deal with this problem with a separate surgery, where I'd make incisions in your scalp, pull the skin back, and then place the drill against your skull and rotate it until I cut a hole in there, pull the plug of bone out, and drain the blood out of your head. So basically what you're saying is I could knock you out, immediately perform another surgery on you in order to perform the first surgery. Does that sound like a great idea? No. So we're not going to do that. We're not going to give you a concussion or a subdermal hematoma just to help you operate. So when you see in movies and guys hit each other and someone smacks the other person blacks out and lands on the ground, you can bet that person's would have in real life probably been dead. Because the fact is that if you black out from a blow to the head like that, it's incredibly dangerous, and depending on how long it takes for you to recover, it could potentially be life-threatening. So if it takes a couple of seconds and you recover immediately, it might just be a serious concussion. If it takes you minutes to wake up, it might be subdermal hematoma or something more severe that could potentially cause a life-threatening injury. Now, when it comes to the amputations, surgeons are going to be performing these, again, without pain medication. We've already talked about having the skin cut to produce the flap. And then your surgeons are going to go ahead and they're going to start the actual cutting on the serious skin and muscle. Now to get through this, again, saw, still not the greatest tool. So what your surgeons are probably going to go to next is going to be a large knife like this one. So you got a very sharp inner edge, and the idea here is you place that against the skin and muscle and then just cut straight down through the skin and muscle to the bone. Now you still have a couple of things you got to get through from after that. You have ligaments and tendons that connect the muscle groups to each other, and you also have a leathery covering over the bone called the periosteum. So first thing, you're going to cut the ligaments and tendons, and then use this knife to cut through the periosteum. Now, of course, once we've separated the muscle and the skin, that kind of floats over the bone. So once we cut the ligaments and tendons, the guy on the top here, he's going to go ahead and take that sleeve of muscle, pull it up. The guy on the bottom is going to take his sleeve of muscle, pull it down, so we expose the bone, cut through the periosteum, and then once we've done that, the surgeon can then, now finally, go to the bone saw, because what's he cutting at this point? Just bone. And so now he can cut straight through the bone itself, use this tool to be as quick and efficient with that as possible. So again, he's going from most efficient tool to most efficient tool to most efficient tool. So he doesn't have one tool that does the whole thing. He's got different tools that all do the different parts quickly and efficiently. That way we're not kind of just muddling through. We're doing every step as quickly and efficiently as we can. Now once we've done this, what's our next concern? The limb's gone, we've separated it away from the body, we now have the open stump. What's our next concern? We got to close it off, right? Now, the first things first, we have major blood vessels that need to be closed, the ones that are being held by the artery, by the tourniquet. So a tool like this called a tenaculum. A tenaculum would be used to draw, to go up, and of course, when blood vessels are severed, blood vessels are elastic, they stretch as you grow, and so when they cut, they actually retract into the body. So when you cut them, you have to actually reach up in and pull them free, and you'd have silk thread around them to tie them closed. So you actually have a silk thread around this that you could use to tie close the blood vessels so they close up. And the silk thread will eventually disintegrate in the body, but during the time that it's there, it'll help close those blood vessels and allow them to seal on their own. Once that's done, the surgeons can then clot the rest of the blood, the smaller blood vessels, the capillaries and such. So once they got the major ones, they'll typically use some kind of restrictor mixture, some kind of clotting mixture they'll place over top of it, usually kind of layered on pads, and then they'll put that over top of it. Let that clot, and then once they've done that, they'll take that strip of skin we mentioned, pull that over, and take a big square needle and sew the whole thing closed. Bandage it up, the wound's closed, hopefully the infection's gone, we've dealt with your problem, and now your wound is closed. Your amputation's complete. Probably not the most pleasant thing in the world, but yeah, it does the job.
I have a question. It's stuff you see in the movies, and I want to see how real life is it.
Sure.
Whenever people have these wounds, whatever in the movies, it's like they grab whiskey and they pour it in the wound to act like it's cleaning it. Did they do that for real, or is that just movie stuff?
It's a hard question because it really depends. There are surgeons in the 18th century who are experimenting with using alcohol as a means of dealing with infection. And actually, it goes much even earlier. You have surgeons in the 17th and 16th century who are trying with alcohol to use it as a means of dealing with infection. But typically, it's used as a tool of last resort, and it's typically done by one or two surgeons who write about it but don't expand upon it. They don't really use it as a standard practice, and it doesn't really gain any traction among their peers. So it doesn't really seem to be something they're using regularly all the time. Like I said, when it comes to infection, vinegar is far more often used for that kind of thing because they consider it clean versus something like alcohol. Now that said, there's still plenty of instances of alcohol being used as a means of keeping things like water supplies clean and stuff. So a good example would be the French, who would actually mix vinegar into their water on military campaigns as a means of helping clean their water. This was something Americans thought was kind of weird, but the French would absolutely do it. So there are times where that would absolutely be the case. But as alcohol is pouring whiskey into the wound and try to deal with the infection, it's not something they would have known to do or cared to do. I mean, the fact is that without germ theory, what are you accomplishing by sticking alcohol in the wound? And what's the point? Why would you do it? There's nothing there. Once the infection sets in, then you might do something. But until the infection's there, there's no obvious problem beyond, you're just hurting. I'm hurting myself. Yay! Seems like a great idea. So as far as they would have been concerned, it would not have been necessarily a great idea. So yeah, that's more of a modern, showing how this one rugged guy is so much smarter than his contemporaries, and is just really a good survivor.
So they didn't do anything like this with cauterizing or anything like that?
Cauterizing, yeah. Mm-hmm. Oh, cauterizing was a common practice. Well, it was a practice used for specific things in some cases. Cauterization was used prior to the introduction of suture needles around the 10th or 11th century, around the 11th century or so. So suture needles are introduced from the Eastern during the Crusades. They're kind of introduced as they go to the Holy Land. Suture needles are started to be identified by the Crusaders, and they're started to bring back that technology to use it in medical trades. But before that, cauterization would have been a little bit more common. By the 17th and 18th centuries, cauterization was considered to be a barbaric practice practiced by the less skilled surgeons. Now, that was if you're using it on a regular basis. There are specific circumstances where cautery makes the most sense. If you don't have really any other option, you don't have a lot of, you don't have suture needles, you don't have ready access to any other form of closure, and the wound needs to be closed. We're not going to leave the wound open in this particular case. We need to close the wound. In which case, cautery would be an option. I mentioned when you amputate, I said you use the tenaculum to pull the blood vessels. You can do that, and then instead of those clotting mixtures, if you don't have access to those clotting mixtures, you can just cauterize the end of the wound and then suture the whole thing closed. That's another option. It's not a great option, but it's an option. Generally, though, they found it to be pretty barbaric because it was seriously harmful to the patient, potentially scarring the patient mentally. I mean, they actually recognized it as being somewhat scarring to a patient on a mental level. And so they didn't like to do it if they could avoid it. That's kind of the idea with cautery. But yeah, cautery was absolutely an accepted practice in the 18th century. It just wasn't, just like today, actually even worse than today, because today we have lasers and we're a little bit more efficient. We have painkillers and things to deal with all of that stuff. They didn't have that in the 18th century. So yeah, it was a little more of a cautious, you were doing it in very specific circumstances, or you were a quack.
Roughly how much time did it take to amputate, say?
That's a great question.
Gave you a couple more minutes.
Yeah, so with a tourniquet, you could safely say that a surgeon should be able to perform the full operation in less than 10 minutes, or less than 15 minutes, was my understanding.
Wow.
So, yeah. I mean, you have a little bit more leeway time once you close the major arteries. So once your tenaculum goes in, you just close the major arteries, and all you have left is clot the blood. That point, you can slow down. You might not suture the wound fully closed for a little bit longer, but yeah, I mean, as long as the major blood vessels are exposed and they have been cut, that's when the clock's ticking. At that point, better work quick because you don't have much option. You don't really have an option. So yeah, I mean, whereas with the blood vessel, with the major arteries and blood and veins cut, you have between 30 seconds and 3 minutes to live. With the tourniquet, that goes up to, I think, 10 to 15 minutes or so. Which again is the reason why you're using specific tools as quick as you can, get through the major things, get them done. But yeah, I mean, there was one surgeon, I think, who was doing it, he was doing it within like 7 minutes or something. But I mean, at that point, it was more of a race, more of a competition. But the 19th century becomes a lot more common for amputations because in the 19th century, the weapons technology they're using actually has pointed bullets with higher velocities. And so those bullets tend to shatter bone more often. And if they shatter bone, we can't fix the wound, we have to cut it. Because that's the fastest way to deal with the wound. There's no resetting the bone if the bone's shattered. So yeah, with 19th century like Civil War bullets, the Benet ball, you're going to see actual shattered bones that are going to cause serious enough injuries. The amputations become the best option to deal with that problem, especially considering the limited resources, surgeons, time that they all have.
How long did surgeons serve? I know enlisted only had supposedly had like 2 or 3 years, something like that, in the Continental Army.
Enlisted men, it depends on when you sign up and what contract you sign, because you have to sign a contract with the Army. Early on, the Army is offering you 1 year, 3 year, and half-year contracts in some cases. Later on, the Army switches it to 3 years or duration of the war. And if they give you a duration of the war contract, you are in it until the war's over. And you don't get a choice. you sign the contract. That's the end of it. Surgeons are commissioned, or either commissioned or contracted through more of a civilian contract. So it could depend. They could have a contract that states they're going to serve for a certain amount of time. If they have a commission, they're in until they're dismissed. I mean, if you're a commissioned officer in the United States Army, you're a commissioned officer, yay! But that means you don't get to leave until they tell you can leave. So you have to actually be legally, discharged. Otherwise, unless they're kicking you out for something bad.
Yeah, no, thank you.
Yeah, that's the benefit of living 250 years in the future.
Exactly.
You know, 18th century surgeons, they could do what they could for the people they had to deal with, and what they could do was better than, you know, not having anything. But at the same time, 250 years of advanced medicine. In the 18th century, I would hazard a guess that a person living in the 18th century would say that 250 years before then, they would still rather have
Right.
what the surgeon was doing at that moment. There's a question I gave to one of my coworkers recently. I said this trick question has one correct answer, and the question is, if you had to go back to any period of time and live your life from that moment forward. So you imagine you have however long left you're going to live, but you go back to a period of time and you just get to live in that moment. You don't come back, you don't go anywhere else, you just stay there. What time period would you go to?
1 minute ago.
1 minute ago is the correct answer. Yes. Because you live in the best possible time in all of human history. And it will only get better.